All right. Hey, brilliant minds. Welcome back to NeuroClarity, the podcast where clinical neurology becomes crystal clear. My name is Nowari Victor, and I am your host. Today, we are going to be doing something entirely different. This series is based on the journal called Neurology, and we are going to focus on pearls and oysters. Pears and oysters journals are basically based on rare but increasingly recognized neurological conditions, and to this condition is on GFAP astrocytopathy. GFAP stands for clear fibrillary acid protein. Buckle up, sit tight, and enjoy the ride. This case starts like an infection, masquerades as cancer, and responds miraculously to steroids. Let's explore this chameleon called GFAP astrocytopathy. Our patient is a 50-year-old man from Hong Kong. 10 days ago, he had what seemed like a routine viral illness, just some myalgia, cough, and fatigue, nothing alarming. Just then, neurologic symptoms began to roll in. First came urinary retention, then dysarthria and diplopia. He became ataxic and soon encephalopathic. On initial workup, his non-contrast MRI was normal, but with worsening symptoms, a repeat MRI with gadolinium showed basal leptomeningeal enhancement. The CSF revealed lymphocytic pleocytosis, elevated protein, and notably eosinophils. Empiric treatment for tuberculous meningitis was started, and at first, he improved on steroids. But here's a turning point. After the steroids were tapered due to GI bleeding, his condition worsened again. Now, pause for a moment. You're facing a febrile patient with leptomeningeal enhancement, eosinophils in the CSF, and fluctuating neurologic symptoms. You've ruled out TB and basic infections. So, what's going on? Let's shine some light on this. Imaging is often the first place GFAP astrocytopathy whispers its name. Initially, this patient had smooth leptomeningeal enhancement in the spinal cord. Later MRIs revealed a key clue: radial perivascular enhancement radiating outward from the ventricle. That's what some people call the firework pattern. This imaging sign, while not exclusive, is highly suggestive of GFAP astrocytopathy. Let us quickly run through what you might see in this patient. First, you may see leptomeningeal enhancement in about one third of cases. Secondly, you may see radial perivascular enhancement, which is a striking and often pathognomic feature. Next, you may see T2 stroke flare hyperintensities, particularly in the periventricular white matter, the gray matter, and brainstem. And lastly, you may see longitudinally extensive spinal cord lesions. These are not your typical findings for tuberculosis, neurosarcoidosis, or viral meningoencephalitis. And when you see these constellations, especially the radial pattern, think autoimmune, think GFAP. So, how do you confirm it? You confirm with something we call GFAP IgG testing. But here's the kicker: the test is most sensitive and specific in the cerebrospinal fluid, that is, the CSF, and not in the serum. You will want to send the CSF for both immunofluorescence and cell based assays. In this case, The CSF returned positive for GFAP IgG, and that clinched the diagnosis. I want you to also remember that GFAP astrocytopathy often comes with baggage. You can have coexisting antibodies like NMDA receptor antibody, aquaporin P4 antibody, or myelin oligodendrocyte glycoprotein antibodies. And up to 25% of patients may have underlying malignancies, commonly ovarian teratomas in women or thyroid or lung tumors in men. In summary, once you've made that diagnosis of GFAP astrocytopathy, your work isn't done. A full paraneoplastic workup is mandatory. Here's the good news. While this disease might be frightening in presentation, it is highly treatable. First line therapies include high dose IV methylprednisolone, plasmapheresis or IVIG, and for long term control, rituximab or mycophenolate mofetil. This patient responded beautifully to steroids alone, and once restarted, his symptoms rapidly reversed. In most cases, steroid monotherapy is sufficient for a monophasic cause, but in relapsing cases, especially those with coexisting antibodies or neoplasms, long term immunosuppression is warranted. Here's another kicker. About 70 to 90% of patients will have a favorable outcome, defined as MRS of 0 to 2. Early diagnosis is equal to better outcomes every single time. Before we wrap up, there is something I need to address. I said something that may sound alien to some hearings, and that is the MRS. When discussing outcomes in neurology, the MRS, aka Modified Ranking Scale, is a standard way to describe the level of a patient's recovery after neurologic illness, especially stroke or autoimmune encephalitis. It basically helps us to measure how disabled someone is after a brain illness. It goes from 0 to 6. 0 means no symptoms at all. 1 means you can do everything you did before, even if you have mild symptoms. 2 means you can take care of yourself, but you might need little help with harder tasks. 3 represents moderate disability. You can walk on your own, but you may need some help with daily activities like dressing or cooking. 4 refers to moderate severe disability. You can't walk or take care of yourself without help. 5 means severe disability. The patient is bedridden, needs constant care, and is totally dependent on others. 6 means death. Here's the good news. In GFAP astrocytopathy, if it's caught early and treated, most patients recover with an MRS of 0 to 2, meaning they live independently and return to their normal lives. Let us wrap up with some high yield NeuroClarity pairs. When you see radial perivascular enhancement on MRI, think GFAP. Don't let eosinophils and fever trick you into assuming TB or parasitic meningitis. GFAP IgG testing should be in CSF and not serum alone. Remember the paraneoplastic connection. Search for an underlying malignancy. And most importantly, this condition is highly treatable with steroids and immunotherapy. Your ability to recognize this pattern can change the trajectory of someone's life. And that's a wrap. Thanks for tuning into NeuroClarity, where complex neurology becomes crystal clear. If you found this episode helpful, you can share it with your colleagues, you can like, and you can subscribe for more case based neurology insight. Coming up next is ADCY5 related dyskinesia from a long standing misdiagnosis of drug resistant epilepsy. This is going to be a tough one for me, but until then, stay curious, stay sharp, and never stop learning. Bye for now.